Good day, everyone. Welcome to this brief presentation supported by Medscape and in conjunction with KDIGO, entitled Beating the Blues in CKD. As you all know, the World Anemia Awareness Day was a few weeks ago. My name is Matthew Weir. I'm a professor and chief of nephrology at the University of Maryland School of Medicine. With me today, I'm quite happy to see a good friend of mine, Kirsten Johansen, who's professor and chief of nephrology at the University of Minnesota and director of nephrology at Hennepin Healthcare in Minneapolis. Hopefully, my good friend Steve Fishbane, who's chief of nephrology at the Zucker School of Medicine at Hofstra Northwell, will be able to sign on, but unfortunately has been having some technical difficulties. So I want to emphasize to all of you that anemia is a common problem in CKD. It's often under-recognized and under-treated, particularly in people with chronic kidney disease. And I think one of the most important issues is that iron deficiency is particularly under-recognized and should be treated first and foremost, because obviously other therapies for the treatment of anemia are not effective in the absence of sufficient iron for the red blood cells. And iron deficiency uniquely affects people who have both non-dialysis dependent CKD as well as dialysis dependent CKD. So we'll first start with non-dialysis dependent CKD. And Kirsten, please give me some updates and thoughts concerning some of the problems with undertreatment of iron deficiency in these patients.
Yeah, absolutely, Matt. Thank you. In my practice, I do see that iron deficiency is often not recognized or treated. I see people focusing a lot on the idea that there's not enough erythropoietin in the setting of kidney disease, and people sometimes forget how common iron deficiency is. And then when it comes to treating iron deficiency, I think there's a lot of under-recognition of the trouble of iron absorption in people with CKD. You know, hepcidin levels are high either because of kidney disease itself or sometimes because of inflammation, and therefore people taking oral iron often don't absorb it. I often think that they see all the side effects and little of the benefit. So I think that that people should consider IV iron treatment more often perhaps than they do. Sometimes there are issues with prior authorizations and difficulties getting them, but I've been finding some improvement in that arena lately. And there are, of course, as you know really well, some agents now that can be given in 1 or 2 infusions that are becoming, in my area, much more widely available. I certainly have some thoughts about avoiding transfusion, but I wonder if you want to talk about that a little bit.
Yeah, I'd be glad to, but I think it's important to realize that there's both absolute iron deficiency and functional iron deficiency, largely due, as you mentioned, to those hepcidin levels, which is typically seen in people with malnutrition, excessive inflammation, subclinical infection. And it's really the latter that's a lot more difficult to overcome. And we'll talk about that a little bit more because it's probably seen a bit more in the dialysis-dependent patient. But going back to the point you made earlier about immunologic sensitization with red blood cell transfusions, I think this is really something that we need to be very cautious about. I often see orders written, transfuse if hemoglobin less than 7. Well, I hate to tell you, if you do that in somebody with chronic kidney disease, you could sensitize them.
Yeah.
And really largely eliminate their opportunity for getting a successful kidney transplant down the line. And I think it's particularly important in young people to avoid transfusions as best you can, unless obviously they're actively bleeding or obviously clinically symptomatic. I mean, transplant's the way you want to go in the future for these people.
Yeah, absolutely. It's actually remarkable how much even one transfusion event can sensitize people. And I think it's really important to note, particularly that that sensitization these days doesn't always lead to longer times on the waiting list since after the changes in the kidney allocation system. But what they really do is present a big barrier to living donor transplantation, because if you're 80% sensitized, then there's an 80% chance you're going to be sensitized to a potential living donor. So it really affects the very kind of transplant that we want to be emphasizing the most, that we want to make the most available, not the least.
So if you're going to give anything intravenously, it better be iron, not iron in the form of red blood cells. I mean, I think this is really the critical issue. And I might also add, too, that, so often people with CKD who are anemic, you automatically blame the kidney disease. But I want to emphasize, too, that you really have to rule out other causes of anemia. And in fact, blaming the kidneys, so to speak, is really a diagnosis of exclusion. You have to make sure there's no hemolysis, active bleeding source, particularly in the GI tract. I think these are all critical issues that we need to remember as part of our clinical care for people with CKD.
Yeah, I think you're right. I often find that addressing iron deficiency can stave off the need for further treatment, for ESAs, for months, if not longer, in some cases.
Well, good. Well, let's turn our attention now to the KDIGO recommendations, which, as you can see here, are quite straightforward. And again, I want to emphasize that as part of the evaluation process, you should obviously be excluding other issues that could be involved causing the low hemoglobin. Typically, I get a TSAT and a ferritin level. I think, wouldn't you say that's pretty typical for what you do too? And obviously correcting any other causes that may be leading to a reduction in red cell mass.
Yes, I rely on those the most. I'll be honest, I don't check absolute reticulocyte counts maybe as often as I should, but I always check iron, TSAT, and ferritin.
It's probably smart, at least at one point, make sure they have adequate B12. All you need is really one piece of meat and you're good for many years, unless you have B12 deficiency. And again, people with autoimmune disorders, that may be a more common problem. And of course, folate levels for nutritional deficiencies. All right, well, let's turn our attention now to dialysis-dependent CKD. And this is obviously a problem. It's a near universal issue. Kirsten, what are your thoughts here about strategies in this particular case?
Well, I really think that the basic strategy still remains the same, which is iron and ESAs, but iron first, and making sure that we're giving adequate iron to our patients so that they then can respond to the ESAs that we are giving them.
Yeah, I totally agree. And I love the second bullet point here, that IV iron may mask occult blood loss. And that's why I think we as clinicians, first and foremost, need to make sure there's nothing else going on before we, again, assume it's the kidneys and obviously focus on iron repletion strategies.
Yeah, for sure. I wish Dr. Fishbane were here to help us talk about this too, because I know he feels strongly. But almost all dialysis patients, if nothing else is going on, 50 to 100 micrograms of iron per week should be enough to keep people iron replete. And if it's requiring substantially more than that, especially on a consistent basis, then I think people should be thinking about GI blood loss in particular, but any other loss of blood besides through the dialysis circuit. And then I've sometimes had an issue. We have to be very conscious that oftentimes we know the data, we know what we're giving in the dialysis unit, we know the lab values, but our colleagues in the hospital can't always see that. And I've had GI consultants think that because someone's not iron deficient, we don't need to be worrying about GI blood loss. So sometimes we need to make sure that we're being effective in conveying what's going on as well.
Absolutely. And then the other issue that comes up more so in dialysis-dependent patients are those that tend to be ESA resistant typically due to functional iron deficiency, meaning they have adequate iron stores, very robust ferritin levels, sometimes even over 1200. Yet, we are really obligated to keep ramping up on their ESA doses. And, again, I get a little bit worried about when I'm pushing my ESA doses much over, 20, 30, 40,000 units a week. I mean, this is really supraphysiologic levels of erythropoietin. And I might add, particularly in people who have high blood pressure, because again, concerns about stroke. What do you do under those circumstances?
Well, I agree. That's a really thorny problem. And, estimates vary depending on how you define it, but it's up to 20% of our patients where we have these issues of either not being able to achieve our target hemoglobins and or needing, as you said, really high ESA doses to do that. And I have the same concerns that you do, that we may be causing harm in terms of high blood pressure, et cetera. So mostly what I do is, as you said, keep pushing, but I hesitate to get above about 40,000 units a week because I'm not convinced that you get much more out of it, even though you keep going higher.
Yeah, you might be having more vascular risk than benefit under those types of circumstances. I think the other issue too is, the issue of giving more IV iron. I mean, it's interesting, they say ferritin's 1200, probably should stop giving iron, but then again, we know iron can overcome some of the hepcidin block. But, now with the HIF stimulators available for the first time, we may have a way around this type of functional iron deficiency.
Yeah, I think that's going to be really interesting. Of course, the trials have shown that these agents are very effective in treating anemia, very comparable to ESAs in terms of their efficacy. But I don't think that the trials were really designed to see how they did for those who are hyporesponsive. And so I think I'm very excited to see what happens as we start using them clinically. And I suspect that this will be the patient population where they get used the most in our country initially.
Yeah, I would agree with you, Kirsten. As I've looked at the data, it does appear that they do provide some important opportunities for correcting hemoglobin, regardless of the hepcidin levels, which I think is an important opportunity. But yes, purposeful prospective clinical trials and high hepcidin patients have not been done. This is all kind of a retrospective look at the available data. But that 20% of people that are on these gargantuan doses of ESAs, I do think it's going to provide an important new opportunity. Again, they're oral, which also is a bit more friendly, and particularly for people on PD where they don't want to come and get, an injection or whatnot. Making use of your ambient iron stores certainly is going to be an important opportunity. So all of us clinicians are going to need to gain some experience in that regard. But again, I still think having adequate iron stores on board first and foremost is key. And even in people with heart failure and reduced ejection fraction, there is data even in people with decent hemoglobins that if they are iron deficient, that repletion with iron can actually improve ejection fraction. So I think that's also something else to think about. Any other thoughts here, Kirsten, as we near the end of our time?
Well, I know that we've emphasized this a lot, but I am very aggressive with iron in both the non-dialysis dependent and dialysis dependent populations because I believe that it's important to avoid iron deficiency.
It's so safe and simple for the most part now. There are multiple different preparations. They're reasonable cost. And remember, everything else doesn't work unless you have adequate iron stores on board. And I think that's the key.
Exactly.
Nothing works without iron. You need it to make the red blood cells. And again, try not to transfuse. So I'd like to thank you all for participating in the activity today. You can scan this QR code here and get your CME credits through Medscape. And thank you all very much for listening in. Kirsten, it's been great working with you. I know we missed Steve Fishbane, but hopefully we'll get him on the next go round. Have a great day.
Thank you.